I think we're all set.
All right, well, I think we have quite a few people on the meeting already, so interest of everyone's time, we'll go ahead and get started. For those of you who may not know me, I am Gail Bradley. I'm the medical director for the Bureau of EMS and Trauma System. I have asked Dr. Gaither to serve as the chair for this committee, and I will turn it over to him in just a minute. He brings great perspective as the EMS Fellowship Director at the U of A, as well as the Medical Director for Tucson Fire Department and a member of several of our standing and statutory committees. So thank you, Josh, for being willing to chair the committee, and I will hand it over to you.
All right, thanks, Dr. Bradley. So there are a lot of us on the call. I would like to go around and do brief introductions, if we can limit it to simply your name and your primary title. That would help us. So actually, this is going to be really difficult, I just realized. It was a nice plan. I'm going to can that plan. Let's try this instead. This is a great opportunity for us to use the chat function. So if everybody wouldn't mind, try out the chat function. Let's try this. Why don't you type your name and your primary affiliation or title into the chat. That'll help Shelly with attendance, I would guess, and it will also prevent us all from jumping over each other. So take just a few minutes to take care of that.
Do you want me to do the housekeeping script?
Yeah, perfect, Shelly. Why don't you do that while we're waiting for attendance?
All right. Welcome, everybody. If you hover your mouse over the bottom part of your screen, the buttons appear for the audio on and off to hang up or leave the meeting, and then for the video on and off. There's also a raised hand feature. Attendees, please be advised that this meeting is being recorded and will be posted on the ADHS website. So anything said verbally, anything viewed via webcam, or anything typed in the chat will become part of the recording. Please mute when not speaking. I'm displaying materials unless requested otherwise. We'll monitor the chat area and the hand raising function to organize people if they want to speak. If you're attending by phone only, you may need to press *6 to unmute yourself. Thank you for attending, and thank you for your patience in advance.
Excellent. Thank you, Shelly, and thanks to all of you for attending. It looks like we have really great representation from across the state. Because we are such a big work group, and this is truly a work group, I would ask the following, kindly request. Please use that raise your hand function if you would like to make a comment, and I will try my very best to get around to you. If for some reason I don't see your hand up, please type a comment in the chat. I have that up also, and I'll try to watch both of those and make my way back around. With that, I'd like to ask Dr. Bradley to give us a brief overview of number 2 and number 3 on the agenda.
All right, thank you. So I wanted to kind of give a little bit of background before we really get into kind of the goals and objective of this work group, and just to explain a little bit of kind of the current state of what is allowed in the pre-hospital setting for blood product administration in Arizona. And I think this has come up over the last year in a number of different settings. I know it was discussed at the Trauma Program Managers Work Group. It's come up at STAB, and I believe at TEPI as well as some individual agency requests to the Bureau. And so I think sometimes to break it down into different types of responses helps to paint the picture and maybe make it more clear. So currently, for a 911 response, so the kind of big thing to delineate first is, do we have 911 or an interfacility response? So for a 911 response, if it's a paramedic only, blood products are not in the scope of practice or drug table, so blood could not be administered in that setting. If it is a 911 response with a nurse and a paramedic, blood can be administered by the nurse only, and that is per the nursing board for Arizona. So kind of a key difference is paramedic only on 911, no blood. Paramedic and nurse, or nurse and nurse, it can be administered by the nurse per scope of practice. When you get into an interfacility, that's where it gets a little bit more complex. So for interfacility transports, if a patient was getting transferred from, say, one facility to another and blood was initiated at the sending facility, a paramedic can transport that patient with blood products infusing, as that is on table 3, which is our interfacility drug box. Same goes for a nurse for interfacility. Again, nurses are allowed to administer blood, so that would be allowable in that setting. So that's kind of the current situation in terms of how blood products are allowed in the pre-hospital setting. So that's just kind of the main thing I wanted to explain. Going a little bit into number 3 here, the part that is a little bit tricky when you look at how the Bureau kind of oversees the EMS system. We obviously regulate all ground ambulances, all EMT, through paramedic level of certification for EMCTs. When you look at air medical, that's where it becomes a little bit different. So the Bureau kind of provides the ability for an air medical unit to work in Arizona. We regulate the paramedic, but the nurse is still regulated by the Arizona Board of Nursing. So I think I wanted to make sure that that kind of delineation was put in there as well. So when we talk about oversight from a regulatory standpoint, air medical, we regulate the actual air medical, like the helicopter or aircraft, the paramedic, but the nurse, if they're working, that would be regulated by the Board of Nursing. So I wanted to give that little bit of framework initially, just to help kind of start the discussion. And I will turn it back to you, Josh. Thank you.
All right. Thanks, Dr. Bradley. Very helpful. So that moves us very quickly through item 1, 2, and 3 of the agenda. I expect item 4 will take a little longer, unfortunately, for everybody. So I wanted to talk real briefly about the work group goals and objectives. And I did want to take a little bit, I guess, of what would be the chair's prerogative to direct the conversation, perhaps right from the beginning, into 2 possible goals and objectives, and avoiding a can of worms, which this group obviously does not have the ability to change. So I wanted to propose 2 primary goals and objectives for this group. The first goal would be, and I'm going to fumble these words, but more or less, it would be to clearly identify what is currently allowed regarding blood product administration in the field. Who can do it? What can they give? And when can it be given, for lack of a real clear definition? That would kind of be an informational product if anyone ever asks the question, I'm a medic down in wherever, and I would like to give blood products. What do I need to know? So kind of information for where we stand currently would be goal number 1. And then I think, and I would leave this obviously open for discussion with a caveat. My thought would be goal number 2 or objective number 2 would be to provide some clear recommendations for when blood use in the field might be considered in appropriate fashion. So some kind of clear, more medical guidelines for use in the field. Comments on those kind of 2 items as an overall work group goal or objective.
I think those are definitely good foundations to start with as a work group.
All right, thank you, Dave. Appreciate it. Garth says sound good. Sharon says sounds good. All right, we're off to a good start then. Perfect. Thank you, Amber, Navira. Brooke, appreciate it. All right, let's dive in then into kind of the first concept. And the first question I'd like to address, and I've typed it out here in 2 different ways. I think clearly identify what is currently allowed, or another way to phrase the question would be information on the use of blood products in our current environment. So let me just start out the conversation, and I'm happy if you guys want to share a kind of working document that may help drive the conversation if you like. Shelley, is that possible before I offer that actually? Can I share my screen?
Yes, of course. Let me stop sharing mine.
Okay. So, present now. I am not a Google Meets user, so this is destined to fail, but I will do my best. You might see all of yourselves. I'm going to guess you can't see that.
It looks small.
We can, Josh. So I think when you go to select what you want to present, you just select like a certain tab or window or document. So you should be able to, we can see your use of blood product in the field and then also the window.
Does not let me select. It only gives me one option. So let's do this. I don't need to see the picture, so I'm going to move this over. Please, if you have a comment, just pipe up or put it in the comments. I'll just make this document a bigger portion of my screen. I will really hope that my kids don't send me any embarrassing text messages during this period, because they will show up. I'm looking over at them right now. Yeah, don't do that. Bad. Bad. Even if I turn it off, it still shows up. All right. I apologize. Can you see that now?
Yeah, Eric.
All right. So kind of the first goal or objective, information on field use of blood products, and put a random date in here as I was listening to Dr. Bradley present. And essentially the first bullet that I put in here is who and when can blood products be given? So I think, and Dr. Bradley or anybody else, please correct me. This was my really quick typing while you were talking. So this would be blood products can be given for a 911 response. Oh, sorry, for a 911 response with paramedic only, blood products cannot be given. For a 911 response with paramedic and RN, RN may administer blood products. Interfacility transport with, and this should probably read interfacility paramedic or RN, paramedic or RN may administer the blood product. And I am going to add on, take a little liberty here. I'm going to assume that is if the medical director approves transport of blood product for that interfacility paramedic. Is that a fair assumption?
Yes, and I think the one kind of differentiating factor between a paramedic and a nurse in the interfacility unit would be the paramedic can monitor a blood that has been started at the sending facility, whereas potentially a nurse could initiate blood because it's still within their scope.
Okay, so I'm gonna maybe perhaps in this draft put that as sub-bullets. So paramedic may, and I'm sorry, Dr. Bradley, you said the term was may
Monitor.
Monitor.
And I believe Noreen and Doug are on the line. So if either of you need to clarify any of my verbiage, please speak up.
Your verbiage is perfect.
Thanks, Doug.
All right, you all have to be tortured by my horrible spelling and slow typing. So, all right, so is that a good summary of current practice? Who and when can give blood products? And obviously, I'll do a little wordsmithing after the fact on this. Is there anything I'm missing from any of the committee members? I see a couple shaking heads. Okay. Again, feel free to use that chat function. All right. The next part of this that I had down is what can be given. And Dr. Bradley, you did not specifically address this. Can you or any of the Bureau staff give us maybe a brief summary of what is allowed under scope, if there are any restrictions on the types of blood products that can be given.
Noreen, I will punt that to you while I frantically Google that, because that's one of the things I look up on our, anytime I have a question, I just go to our Bureau's website and I pull up the drug tables to confirm.
I am looking for the exact language, and just give me a minute.
As I recall, it states simply blood products.
I believe you're correct.
Is there a drug profile on point, perhaps?
I don't believe so, because it's on the interfacility and it's just listed as blood.
Yeah, I don't think we added one to
Gotcha.
the profile for blood.
And drug table.
I think that's why it was considered so safe for interfacility use, is that it was a presumption that it was appropriately typed and cross-matched and ordered by a sending physician. So it was not felt needed. I'm just trying to remember the history of all that.
The table 3 says blood only. It just says blood. It doesn't say products. It just says blood.
Oh, sorry. Okay, so I'm going to go out on a limb here, and then we can correct this as we go. But just to lead the discussion a little, the Arizona Scope of Practice and Drug Table allows for the administration of, quote, blood. Why don't we say something like this may be interpreted as any blood product that matches or is appropriate for use in the patient. Is that kind of a fair statement of your sentiment, Dr. Gamer?
I think. Sorry, it took me a while to get off mute. I just think that is appropriate for the interfacility realm, and when you get into use in the 911 system, it's there's projects that are going on in like the city of San Antonio with a low titer O positive and things that aren't fully cross matched. So it's kind of in the definition is what is appropriate for the patient given the circumstance. Certainly in a controlled situation in a hospital, the type specific bloods certainly is that would be given, but in the 911 projects you don't have that luxury, so it might be defined a little bit differently.
So
if we choose to go that direction.
Yeah, thank you, Dr. Gamer. I think that's so here's what I have as kind of a working sentiment, and this may get into objective 2, which is to provide some recommendations from this group, but I think where we are now is ADHS scope of practice and drug table allows for administration of blood, and maybe what we do is this sentence that I just wrote out, this may be interpreted as any blood product that would match the patient's blood type or be O negative for females and O positive/negative in males. Maybe we would move that to a recommendations at our kind of second work group, because that is not specified in statute. And I did see a hand pop up. I apologize.
And Josh, there's a hand from Dr. Tang, and then also Sharon had some questions in the chat box as well.
Okay, great. Dr. Tang, why don't you go first, and then I will go from there.
Just a couple of comments on what you just wrote. If we're talking about O negative for female, you might have to qualify that it's a female who are within the pregnancy age group, right? So for us at Banner Tucson, we're using whole blood, O positive and O negative whole blood. And we defined the pregnancy age group as less than 50 because it's a non-issue for people outside of the age group or who are outside of the pregnancy range.
Very good point. Thank you. And Sharon, for this issue, interfacility means hospital only, or does it include other start and destination points? I believe, and I would defer to the Bureau staff, I believe this is hospital to hospital, licensed hospital to licensed hospital. But I would defer to Dr. Bradley and Noreen and anyone else with more information.
I believe we have a definition in rule for interfacility that's defined, and I'll look for that language while we
I posted that in the chat.
So Amber added that to the chat, that it's a healthcare institution. One of the things that's a little difficult is the definition healthcare institution is a little broader than we probably want it to be. At least it was last time I looked at it. Does anybody have that in front of them?
Just to let you know, from the Department of Health standpoint, we cannot redefine what a healthcare institution is. That's part of hospital licensing. We do not have that authority. So that is defined. So anything, if we're going to do work with definitions, you're talking about rule changes, and I think you're going beyond the ability of this work group. And I will look at what, you know, in the interim, I will look for what the interfacility actually means in definitions.
Thank you. Before I kind of move on to what can be given currently, and then obviously this will be a recommendations later, what should be given. Any other comments on what can be given? My inclination, kind of hearing the sentiment of the group, is for now, we would leave this as pleasantly vague. Okay. Hearing and seeing nothing else in the chat. My other question, and I don't have an answer to this, but the other question that I had kind of written down was, when can blood be given? And that's kind of answered above. I don't know that we need to really include this in our current information on field blood use, but I did want to bring it up for discussion. My thought on bringing this up for discussion now is there is no guidance or criteria for administration of blood. My understanding, there is nothing to say you have to have a blood pressure of less than 90, you have to be tachycardic, you have to, no restrictions in that for that direction. I'm going to take no comment, as I'm going to delete this from the document, from our current guidelines, unless anybody objects. Andy, what do you have?
Hey, Josh, I just want to understand the purpose of this document one more time. Maybe I didn't catch it in the beginning when you went over it. But what is the purpose of this document? Because that will affect the details of it.
Yeah, and that's a great question, Dr. Tang. And just to be clear, I'm using this as my notes for the meeting. This is kind of how I am jotting down the opinion of the committee. My experience with these work groups in the past is that generally the work group provides recommendations back to the committee, which ask it to be formed. So kind of where I was headed with this is that in the past, similar committees have developed guidance statements or other similar guidance documents that the DHS provides to anyone that has a question or concern about a particular topic, in this case, use of blood products. So I was using this as a way to take notes, quite frankly, with the idea that it may eventually go that direction should STAB request that.
So I think, from what I see is if this is going to be used as the basis for the committee to make a decision on pre-hospital use of blood products, then what type of blood product is to be used, and the indications are probably the crux of the conversation. And so I think we do need to have, I mean, if that's why I was asking, what is the purpose? So if that's where it's going, I think it's probably worthwhile generating some indications.
Yeah, thank you. I agree. And I think that's where I was getting to in the second part is recommendations regarding the use. But I really wanted to clearly outline where we are coming from before we go to recommendations. And I think I do want to give a caveat here. I don't think, I have to think about this. I don't think that the goal of this work group is to make recommendations on any changes in statute or scope of practice. I think this was mostly to share information. That was kind of where I was headed with it. So.
And Josh, I can just tag into that a little bit. We wanted to make sure we really had a forum for discussion because this has come up in so many different settings and comes up pretty frequently as a question. And so we really wanted to kind of, get an idea of what is where we are currently. What is evidence support, especially in Arizona, which it may be different from other cities and kind of in terms of ability for EMS to respond, response and transport times, and then figure out if there would be a recommendation that could go to STAB, keeping in mind that anything that would potentially be a scope of practice change would have to go through the process for that, which we just kind of are finishing an update to scope of practice that's going to go through the public rule comment shortly. So there are some kind of limitations of what we could do with this committee, but I think it's just a really good opportunity to kind of bring this up as a conversation piece because it has come up as a question in a number of different settings, if that kind of explains a little bit more.
Thank you, Dr. Bradley. So I think before I move on from our first kind of goal, which is to clearly identify what is currently allowed, anything else that you would like to add, any committee member thinks this is important to add to what is currently allowed?
Josh, just all I can add is what I've been typing into the chat. I think we have the opportunity to narrow down the scope of healthcare institutions by just defining the sending healthcare institution as having started the blood infusion. So presumptively they have that capability and are some sort of hospital or fairly well-developed clinic, at least, and then transferring to presumptively a higher level of care, or at least a facility that can accept such an infusion. So we get around having to redefine healthcare institution. We just kind of narrow it down. And then I like the current statement that you have here, a blood product that would match patient's blood type or be O negative with the qualifiers or O positive O negative. So I think we're on the right track here.
Okay. Thank you, Dr. Gamer. David, you had your hand up.
Yeah. So we have 100 sites that we're currently using blood products at, and we're just about to do a study looking at whole blood versus the other blood products to see if that's going to be as effective as we need. We've also worked with the Panther study and a couple of the other blood studies out of the Kentucky area. I have a protocol that we've written that I could share. It can't be on a public website, but I can share internally with you all. That might help with this.
Yeah, thank you, David. I think I'm going to come back to you here in just a minute when we get to the recommendations for moving forward, because I think that is a valuable discussion.
Okay.
Whole blood versus PRBCs versus component therapy is a great question. So let's come back to that in a minute. I think I missed somebody with their hand up earlier. Any other comments on our what's currently allowed before I move into recommendations for anyone who might be considering this? Okay. Thank you all. Then let's move on to kind of our next goal or objective, which would be recommendations regarding the use of blood products in the field. And let me clarify this a little before we dive in. At least in my mind, I think my goal here is so if I, as the medical director of Tucson Fire Department, say, what should I do? And Tucson Fire Department's a bad example because we can't do this. There's not allowed under scope of practice. But let's say I was the medical director of an air medical company, like you mentioned, David. What would best practices be if I were to implement a field blood program? So I have a couple questions written out. Maybe we should start with this one. David, you alluded to this. What product should be given? I mean, I'm going to clearly defer to our trauma care experts on this topic. I think obviously this would be packed red blood cells. So packed red blood cells are an option, as are whole blood. And I'm totally open to other comments about how we should discuss the differences, weaknesses, strengths. All right, if nobody's going to raise their hand, Dr. Tang, I'm going to pick on you because you know more of this than I do. So, I mean, if you were to make some recommendations, is this something that you feel there is enough evidence that we could make a rank order list of choice 1, whole blood, choice 2, choice 3, or just should we list them out?
I mean, your available blood products are Prbc, FFP, platelets, cryoprecipitate, and whole blood. That's your options. And of the ones I mentioned, Prbc and whole blood seem to be, and FFP seem to be in the running. You know, it's not until you've infused quite a few units of Prbc and FFP that we need to catch on with platelets. They don't tend to get depleted as quickly as blood, as Prbc, and the coagulation factors in FFP. And so I think of the various components that we talked about, platelets and cryoprecipitate can probably be eliminated from in-field use, if that's what the focus of the conversation is. And so we're left with 1, whole blood, 2, Prbc, and FFP. I think there is a trend in the country, at least within the trauma centers, to start looking at using whole blood, because after all, when we bleed, whether it's a trauma bleed or GI bleed, red cells, coagulation factors, and platelets. And so whole blood has it all. And we're using that in our trauma bay for that exact same reason. It negates the need to assemble the components, if you will, as we do when we're doing component therapy. So, you know, if I had to choose, I would say, hey, you know, whole blood seems to be the most well-rounded blood product to be used in general. Of course, the limitation is the availability. And also it can be stored as long as the component products. That's the downside. So if you don't end up using it, you know, I don't know if it's a couple weeks or something. The shelf life is significantly shorter than component therapy. So if you don't end up using it, it goes to waste. And there's very few facilities that actually have the ability to fractionate whole blood into individual components to extend the shelf life. Of course, that adds another component of, machinery, availability of resources and whatnot, and connection with a blood bank. That's the downside with whole blood.
Okay.
There are pre-hospital agencies that are trying whole blood. I think I know there are. I just don't know which agencies they are. I don't think any in Arizona are. There are agencies that carry blood, as you all know, in the field. And when someone bleeds, again, whether it's a trauma bleed or a GI bleed, to replace lost blood with blood rather than saline or LR makes more physiological sense.
Okay. Thank you. That was very, very helpful. Can I ask a follow-up question? And again, I'm only picking on Dr. Tang because I know him. So anyone else, please feel free to chime in too. So I'm seeing this as essentially us listing out advantages and disadvantages for each rather than providing a definitive recommendation. Can we list advantages or disadvantages to PRBC, packed red blood cell, sorry. It's obviously a single component, right? And
longer shelf life.
It's true. And I apologize, Dr. Rice, you did just have your hand up and I accidentally skipped over you.
Oh, that's okay. I was just going to say along the lines of what Dr. Tang had mentioned, that, along the lines of recommending which products to use, that we should provide some sort of guidance as to what the requirements are to maintain these in terms of shelf life, the refrigeration necessary, that sort of stuff, so that it's clear that there are limitations and specific requirements to carry each of these different types of products.
Sorry, so I'm going to add this as kind of a second area, which is more cautions for implementation of a blood field blood product program. And I'm going to put that as a note, temperature, and we'll come back to that in a minute, I think. So I'm going to go back for a second, Amber, and then we'll jump back to the temperature. So single component, longer shelf life, so disadvantage and advantage. Anything else that I should include in there from a medical perspective? Yes, Vicki, thank you for the comment. I think it will be very important for us to defer to authoritative or regulatory bodies regarding storage requirements, and deferring to the FDA and other regulatory agencies is key. So I will add that down here. Okay, thank you all. All right, so next on my list then, FFP, fresh frozen plasma. Disadvantages, advantages to using this. My real question is, if you are implementing a PRBC program, should that include FFP as a component therapy, or are PRBCs considered a standalone field blood product program? Dr. Tang.
Just from our experience, collective experience, people who work in the hospital and give blood, not always do you need to give FFP. Sometimes a couple of units of blood is all you need. And in general, FFP is not one of the first blood products to be given for a bleeding patient, unless you know that they have some sort of coagulopathy, which in the field none of us do. So I'm not answering your question, but I'm simply introducing a statement that they don't have to be used in conjunction. There's plenty of times when I give blood without FFP.
I see there's a question regarding if there's massive transfusion protocol initiated, would FFP need to be brought in? I guess the question in that setting is, would we be potentially initiating a mass transfusion protocol in the pre-hospital setting or not?
Are there any pre-hospital agencies that carries enough blood products to be considered a MTP ready system?
None that I'm aware of.
So I don't know if that,
No, I don't think so. The requirements to thaw it and everything else are beyond
that
most pre.
that was my thought as well. So I don't know if that, you know, I don't know, Dave, your question if
I'm thinking more of like a interfacility or a patient gets taken to an outlying facility and we're bringing them into you, that they provide us with that. We've done that numerous times, that we've supported that.
I see.
Apologize. Maybe the way to modify this statement should be considered, FFP can be considered if more than 2 units are going to administered, there is a known coagulopathy, or the patient is being transferred between facilities on an MTP protocol, something like that. Obviously, that in that case, platelets would also be considered. All right, and then last one on the list, platelets and cryoprecipitate, not recommended for field use unless as part of an MTP protocol. All right, and I think Vicky is talking to some extent. Vicky, a question for you about your comment in the chat. Liquid plasma. Are you? I'm not familiar with anyone that carries plasma in an unfrozen form. Is there some people who? Maybe the chat may be the best option. No problem at all. While Vicky is responding to that, perhaps in the chat, I know there are some synthetic blood products. I don't know of any that are currently approved for use, much less approved for use in the field. Feel free if anyone knows more about those synthetic products. Is that something we should include in here?
Hey, Josh, one thing to consider is PCC, prothrombin concentrate.
Sure.
I don't know if that's what you're alluding to. It's not synthetic per se, but in some ways it is. And I think in some ways that's equally effective for certain types of coagulopathy. Right? If you have a cirrhotic with a deficiency in coagulation factors who have a massive GI bleed, PCC infusion will very easily and quickly correct that coagulopathy. And in trauma also, we use that in trauma quite frequently as well.
Agreed. How long does it take to infuse PCC? I actually do not know.
Fast.
Yeah.
And I'll reverse an IR&R within 15 minutes.
Yeah, my thought as I add this on here is this something we even want to address? Because one, it's very limited availability, and two, it can be infused at facility 1 really quickly and not necessary during interfacility transport. It is so expensive, I doubt any EMS agency would ever purchase it.
Good point.
Okay, let's eliminate that then. Okay. And I will include this O negative statement, obviously, in here somewhere. I'll put typing. I'll clean this up down the road so I don't waste your time. All right, so I think building into the next topic, what Dr. Rice commented on, which is cautions for implementing a field blood program. So again, if you are currently allowed, we talked about storage requirements, storage per FDA and other regulatory agency requirements regarding temperature and shelf life, right? Anything else regarding storage? It looks like Brooke says liquid plasma has a 26-day shelf life, but does not need to be refrigerated. Thank you. And Vicki, it looks like the University of Cincinnati is using some liquid plasma. So I will P/
I mean, the other thing to consider, Josh, would be the sort of like what size of agencies would use blood enough maybe to make it something that's acceptable in terms of the use or potential waste. I can imagine that there might be some smaller agencies that this could be a problem with if they don't think about the volume. I don't know.
Yeah, so really, I think what you're saying, Dr. Rice, is that shelf life and conservation of resources should be considered. Considered and waste shelf life and conservation of resources should be considered and plans implemented to prevent waste.
Yeah, so and along those lines, and like quality improvement initiatives for agencies that use field blood, I think would be another important topic.
Yeah, so that gets to kind of appropriate administration, I guess.
Yeah, I mean, I think you have to have the ability to do strong quality improvement to be able to initiate something with this much, potential for waste and loss.
Strong program should implemented to ensure appropriate use. Appropriate use and prevent waste. Fair. And I apologize again. Someone just raised their hand. I think it was Dr. Gamer.
Yeah, Josh, another thing that has to be, full disclosure, I got involved with this because the current fire chief down in San Antonio was an assistant chief at Phoenix. And of course, those people talk, and San Antonio's got going a pretty robust project. So, basically I was ordered to look into this, and I talked to Dr. Paul Dabrowski about getting involved with this, and he said that he would be happy to help out. And what we did was we went to the blood bank and down at Banner University, and this was right about the time COVID started rearing its head, and it was going to be tight to get the blood bank involved back then. But what I'm saying is that a very very strong partnership with a blood bank is needed. What San Antonio does is they get the units of the low titer O positive blood. They're understood to have like shelf life of 21 to 23 days. They put them out in circulation for 14 days, and then they work with their blood bank to rotate stocks. And I think that the last time I heard Dr. Winkler from San Antonio present, they'd like wasted 1 unit out of all the units that they'd had in circulation with that kind of theory. Josh, I think you probably heard C.J. Winkler talk at NEMSP as well. and you know, they've kind of gone a long way in inventing the wheel in this regard. I'm not saying it's going to work here in Arizona, but they've thought of all these things, and I've got some materials, and when time comes, I've got sample guidelines to circulate as well.
Thank you, Dr. Gamer. I think, yeah, the San Antonio program is interesting. I would give the caution that that is also a very strongly military-linked community. They have a very, very large military presence, and obviously the military has a very different utilization model for blood than we do, mostly because of their very, very long transport times. I wanted to perhaps segue into a related question, and we can come back and forth between the cautions and this perhaps. I do feel that, Dr. Gamer, building on what you said, the question that you're asking is really, when should blood products be given? And I feel, at least personally, this is where I would appreciate some recommendations from the trauma groups, and I use that plural on purpose. Are there strict criteria that EMS agencies should be following when blood is administered? Crickets. So David put in here, thank you, David, acute hemorrhage with hemoglobin less than 7, signs of shock in the setting of acute hemorrhage, evidence of hypoperfusion, pale, vasoconstriction, cool, hypotension, or tachycardia. So I am going to, quite frankly, just steal this, David, for sake of discussion, and ask that we kind of work through this as a group for some possible recommendations. And of course, it is going to take up all of my screen here, so bear with me. Okay, that'll fit a little better. So I'd like to, just because this is fairly nuanced, I'd like to have a little bit of a discussion about each of these points if you all are up for it. Acute hemorrhage with documented hemoglobin less than 7. That seems very reasonable to me. Any comments, suggestions, concerns? And there's some more down here, indications for plasma. Dr. Taylor?
Well, here's my concern about using the hemoglobin of 7. Oftentimes when someone acutely bleeds and you get a stat hemoglobin, that number does not reflect the actual status of the patient. It lags behind. It also depends on the speed at which a person bleeds. So if someone has a hemoglobin of 10, but they're just pouring out blood, I'm going to give them blood because that 10 is not real. And that 10 can become a 6 within minutes. So the hard, fast number can be misleading. That's my only concern.
I think when we built this, it was the intent that if we had a lab showing 7, or we had signs or symptoms showing the rest of this. So I think it's an and or.
The study looking at a hemoglobin less than 7 was done in the critical care patient, in hospital critical care patient, not in the acute bleeding patient. And so we just have to keep that in mind as a caveat.
Guys, I wasn't on mute. So I think what I'm hearing, Dr. Tang, is acute hemorrhage with documented hemoglobin less than 7. Do we want to put something like, maybe we do a list, right? So, or signs of shock in the setting of acute hemorrhage regardless of measured hemoglobin. That kind of gets the sentiment. Evidence of hypoperfusion and peripheral vasoconstriction, cool pale skin, delayed. So I guess this is in the setting of hemorrhage. Is that correct, David? So this would be hemorrhage with evidence of hypoperfusion, including, and then this is essentially, and this is probably my cut and pasting error, pallor, peripheral vasoconstriction, delayed capillary refill, and then the great, a fair representation. Okay. I'm reading through the comments here. Following this, David posted the indications for plasma, which is DIC, and that's very specific to plasma. And aside from interfacility transport, I don't know that anyone's going to know that we have DIC. I'm a little hesitant to throw that in there. Thoughts from the rest of the group? Would not be known, says Vicky. That's understandable. Okay. Acute uncontrolled hemorrhage. So this is essentially anytime you're going to use the MTP, signs of acute hemorrhage that is uncontrolled, ongoing blood loss, loss of greater than 50%, loss of 100%. I think all that is very specific to plasma.
Because it was
I don't
done.
think we would know that in the field.
It seems to me the most useful triggers for activating the field usage would be really based on patient's clinical status, hemodynamics. Because you really, most of the time, we don't have the luxury of labs and or any guesstimate of exactly how much blood was lost, because oftentimes those are inaccurately measured. Even in the operating room, we measure inaccurately. So I think really what we really have is just the patient's hemodynamics and their physical appearance, to be very practical.
Yeah. So really what you're saying is the decision to transfuse should be based on clinical signs of shock. Or
yeah.
Significant blood loss.
Josh, if you get to, if you can get to your email, I tried to forward the San Antonio guidelines, and they're pretty much, as you stated, based on physiologic findings with evidence for hemorrhage. They don't get into hemoglobins and DIC and that sort of thing. Also, they're kind of worded so that if resuscitation starts with crystalloid, then you can segue into blood when it becomes available as well. So, you know, I think they might be useful. I don't know if my other computer is sending them.
Yeah, I'll pull it up. Probably take a look at it offline here. And
okay.
Great. I kind of see this as being an iterative process, just so we're all on the same page. This is essentially our let's rough out a concept. And then we'll circulate the concept once I correct my typos and ugliness back to the group. All right, so we have kind of a general idea of when blood products should be given. I'm gonna check the chat real quick. Thank you, Jody. Hemorrhagic shock by evidence of systolic less than 70 or 90. I think we got those numbers in there. I guess you do bring up a very good point, Jody. One thing that I consistently talk with my providers with is the concept of permissive hypotension in the field. And obviously the literature regarding permissive hypotension is quite old. That's from, I think, the 70s even. And only saline resuscitation was available at that time. So I guess my question for the experts in the room is, I am comfortable with hypotension being defined as a systolic less than 90 and penetrating trauma if we are giving blood products. Obviously, it would be different if we were giving saline products. Comments or thoughts on that?
This is Gail. I think one of the issues too, that as Arizona has kind of become an epic TBI state, is recognizing that in the pre-hospital setting, many of these patients have multi-system trauma but have head injuries, and so I think that's one of the precautions to keep in mind. If we save a body but their brain's not alive or functional, we haven't necessarily done a lot of good for that patient. So kind of keeping that piece. And I always kind of use the Terry Mullins approach of we are ADHS, we are the Department of Health. So we always have to make sure we kind of spread the public health message. And so one of the public health messages is conservation of resources. So just kind of using that precaution as we look about, as if we were to suggest implementation of a kind of pre-hospital blood product program in the 911 setting, keeping in mind that we really don't want to have any kind of wastage going on here, because that really is one of the things that kind of goes against a public health initiative. So I have to throw that plug in.
Thanks, Dr. Bradley. I want to circle back to that in just a second. Dr. Tang, you had a comment also, though.
Well, I was going to say, Josh, in response to what you said, damage control resuscitation, hypotensive resuscitation is a principle in damage control resuscitation, which is what we employ on a daily basis in trauma care, whether it's penetrating trauma or blunt trauma. You know, and whether or not we're using crystalloids or blood products. So I think we don't need to make that distinction between penetrating versus blunt. And I think the principle is very much alive.
Okay.
We published a paper regarding this, looking at the systolic blood pressure, and we found a systolic blood pressure of 80 was the inflection point. That and an end tidal of 24, and that those two, when they cross, you had about 5 to 7 minutes before they went into arrest in the pre-hospital setting with trauma.
And I was going to make another point with what Dr. Bradley mentioned. Oftentimes we have conflicting interests between someone who's in hemorrhagic shock but with concomitant traumatic brain injury. TBI, you want to ramp up the blood pressure. You know, solid organ hemorrhage, you want to lower the pressure. So we don't know what that right sweet spot is that kind of help us temporize both situations. It's just a comment. There's no solution at this point in time. We don't know what that is.
Yep.
But suffice to say, a blood pressure that's low enough for a trauma surgeon to be happy with in terms of hemorrhage control may not be good enough for the brain.
Okay. Thank you, Dr. Tang. If I can, I want to go back for a second. Well, let me actually complete this one before we lose our train of thought. Any other comments or suggestions about when a product should be given? There is one in here, traumatic arrest with CPR. I think that would fall under these categories. Jody, correct me if I'm wrong. And then clinical experience, thank you, Vicki. And then getting back to the judicious waste considerations. So any other comments,
Josh,
indications? Yes, Jody.
I was just taking that information off the low titer O positive whole blood trauma, and I believe it came off the San Antonio. They had guidelines for the hemorrhagic shock as evidenced by the systolic less than 70 or systolic less than 90 with a heart rate greater than 110, or the entitled CO2 less than 25, and then the witness traumatic arrest less than 5 minutes prior to provider arrival, or continuous CPR throughout the downtime. And then the age greater than 65 years or age with a systolic pressure of less than 100 and a heart rate greater than 100. So I was just stealing that off of their criteria for an example.
Perfect. Thank you, Judy. Appreciate it.
Hey, Josh, it's Amber. Can we get comments about the A.R.S? I think that we should be careful in recommending a therapy in a situation in which we've already sort of provided guidance on terminating resuscitation. So I don't disagree that some patients in traumatic arrest could benefit from blood administration, but in the cases where they're a prolonged transport from a trauma center, I don't know that there's good evidence that it may be more wasteful. is what I'm trying to say, to recommend giving it in situations where your transport time is prolonged in traumatic codes.
Thanks, Dr. Rice. I agree with that, particularly in blunt trauma, blunt traumatic arrest. I don't know that there's a lot of evidence to suggest blood products in the field would be anything beyond futile. Any of the trauma surgeons on the call have thoughts on that?
I agree. The survival for a blunt traumatic arrest in the field when they get to the hospital is less than 1% for blunts. That being the case, to give products in the field may be a waste.
So I'm going to put in a statement here to say, essentially, transfusion of blood products for victims of blunt traumatic cardiac arrest in the field is unlikely to change the patient outcome. Is that a politically correct enough statement?
I think so.
All right. All right. Thank you. I do want to go back to, I think, Dr. Bradley's comment a minute ago. David, I'm gonna really quick my Debbie Downer to end-tidal CO2. There is no correlation between end-tidal CO2 and blood CO2 in patients who are medically unstable. It's a horrible marker. So I am really not a fan of using end-tidal CO2 to do anything outside of use it as a way to inform your clinical decision-making. So I'm really hesitant to put it in there. I know it's in the San Antonio program. I know the evidence is incredibly lacking.
Yeah.
Open to other comments.
The reason why I mentioned that is that we use that as one of our guideline points, and saying that if that number goes below there, and we have the evidence behind it to support that. So I exactly agree with what you're saying in terms of the assessment of the end-tidal CO2. But given the resources we have out in our setting, this is another way we can potentially strengthen the opportunity for us to decide when to give blood products or not.
I'll defer to the rest of the docs on the call. I have never, ever clinically used an end-tidal CO2 as an indicator for when to give blood.
This is Amber. I agree. I think that without more literature on that specific recommendation, I think it would be very difficult to include it in what we're intending to be an evidence-based sort of document, if that's where we're going with this, which it sounds like we are. I think that there would be just limited utility, and it could be very misguiding.
This is Gail. I agree.
All right. I've been hearing not a lot of other comments on that. I do want to turn back to cautions for implementation of field product blood. I think we need to emphasize we have strong quality improvement, shelf life conservation. My other caution with this, I think getting to this idea of waste would be the concept that administration of blood in the field should not delay transport. And that in my mind, there is probably a cutoff somewhere, a time threshold. If you were within 5, 10, 15 minutes of a trauma center, it's going to take you longer to set up the blood product transfusion than it is to drive to the hospital. So I wanted to kind of capture that in the sense of cautions. I wanted input, though, from the group.
I think that's an absolute. That there shouldn't be any field procedures that delays the patient's ability to get to definitive care.
Other thoughts?
I think kind of tagging onto that piece, how long it takes you to actually implement something is how often you get to do it, right? So for any procedure or thing we give, whether medication or performing a skill, how often we do that affects how proficient we are. And so I think that's one of the other pieces where if you look at air medical versus ground, an air medical unit is likely to use this more frequently than a ground unit. And so kind of looking at how that affects your proficiency and speed of implementing something like this.
Perfect. So I apologize, my internet is at times a little skippy, but I think I got the gist of that. It looks like kind of the concept would be time to trauma center or another facility capable of giving blood products should be considered, as with the frequency with which blood products are likely to be given. And I think your example, Dr. Bradley, is what I was thinking of. An air medical company that only does critically ill patients is much more likely to use this than I will throw my own agency under the wheels here, Tucson Fire Department, which has a 5-minute transport to almost any hospital that they could respond to. Other thoughts or suggestions on this? All right, the last thing I have on my list, good. The last thing I have on my list that I wanted to discuss before maybe we wrap things up is if you are to implement a field blood product protocol, are there other medications or interventions that should be considered as required under that program? For example, administration of TXA or other calcium or other products.
I think there are agencies within Arizona that are using TXA already, yeah?
Thank you, Andy. That actually, I need to clarify, if Dr. Bradley doesn't, TXA is currently not approved for use by paramedics. It is allowed by nurses, just like the administration of blood products.
Correct, yes. So a ground unit with a nurse on it, they could administer TXA, same with a helicopter or aircraft.
Hey, Josh, did you want to also include in your list up top about who can give blood products, physicians, so field responding physicians as well?
Yes, I will do that. For those of you that don't know, we frequently do have our residents go on transports, particularly interfacility if a nurse is not available, to start blood between our two hospitals. So physicians, I'll add that in. Circling back, any comments? I am inclined to recommend the use of TXA if you are going to implement a field transfusion protocol, but obviously that would be limited to nurses. I have frozen. Oop, you might be back. I'm very sorry. My internet, I think, froze up. Can you all hear me?
We can, yes.
Gotcha.
Okay. Sorry about that. Okay, so sorry, just to go back because my internet glitched. My bullet that I was thinking about putting in here as a caution was field transfusion programs should consider other therapies in addition to blood, such as TXA. Is that a fair statement? Any opposed to that one in there? Brooke says agree. Sean says agree. PHI carries it. So I think that looks like a positive. Okay. So here's where I feel like where we are right now, if I can kind of summarize. I think we have gotten a lot of concepts and ideas. I have a little background work to do from Dr. Gamer's email. What I would propose is that you all allow me to gather my thoughts and clean up this document. And then perhaps we have a second work group meeting to review a draft document that our work group would then present to STAB as the work product of this work group, and then allow STAB to decide what they would like to do with it. Would that be an okay next step for the group? Sorry, Dr. Gamer, you have your hand up.
Yeah, and I think that whatever we come up with as appropriate products to give, or then I think that in table 5, or the drug box table, that has to be taken through the process, the PMD, MDC process.
Yeah.
Kind of a parallel process.
Yeah, Dr. Gamer, I think we're going to stick for this work group to clearly stay within our kind of dedicated scope, and we'll see what comes out of the STAB group. Any other thoughts or comments before I wrap up for this afternoon? And I apologize, my internet is just horrible right now.
Can you show what you have in there in terms of the recommendations for like quality improvement and stuff like that, or for, do we have anything in there?
I only currently have a strong quality improvement program should be implemented. Where did I have that?
I see it there. I see it right there. Would we want to ask STAB to make specific recommendations as to reporting to the DHS? Like who's using blood products and what their, you know, quality improvement and evaluation processes are? I mean, is that something we want to ask STAB to evaluate as well?
I think I need to punt on that one, if you don't mind. I need to think about it, mostly because that gets way into the weeds.
Okay.
So let me, if you don't mind, Dr. Rice, let me think about that, and I will put something on this draft to see what I can come up with. And I don't also want to exceed what we can do. So let me punt, and I will do a little thinking on that and see what I can put on here.
Okay.
All right. Any other thoughts or comments before we close off this meeting for today?
No, a big thank you to you, Josh, for kind of coordinating this effort today. We will work, Shelley and I will work with Dr. Gaither and get out some options for dates to this group. If you were not on the initial meeting invite and are on this meeting today and are identified by a phone number only, please email Shelley Bissell so we can get your name and add you to the attendee list. But we will plan to have another meeting in March. The next STAB meeting is in May, so we do have plenty of time before that meeting. So we will meet in March, and if for some reason we need to meet again in April, we could, but hopefully we can wrap this up in one more meeting.
All right. Thank you very much, Dr. Bradley. Thank you, everybody, for participating, and I will work on this draft and get back to you all.
Thank you, everyone.
Thank you.
Thanks, everybody.
Thanks, everyone.